We're going to have a case discussion today, but we have to lay some groundwork rules so that everybody is on the same page. Normally the title initially was our panelists, but I call them our contestants today. So we're going to have a lot of fun. And so the rule of the way these case management sessions work, and here they all are, is that I get to ask the questions, and then the panelists get to answer. And I have no data slides. There is no correct answer to any of these. I may throw in my stupid opinion on some of these things. So we'll get going and see how the panel goes. So we need to warm you guys up a little bit, okay? And I'll be directing questions to the individuals on the panel here. So the question now, and this is an F&A, so Tarek is going to have his antenna up on this. So the question is, how do you interpret an F&A report not done at your fine institution? And so this is a direct quote. I just copied and pasted this off the report. And it said, the specimen contains several clusters of follicular cells with colloid and macrophages. Some of the cells may contain nuclear grooves and occasional Hürthle cell features. This may represent an adenoma, nodule, follicular lesion, or possibly a papillary cancer. The presence of Hürthle cells raises the possibility of a Hürthle cell cancer. Okay? So, Tarek, how much should I pay for this report? What is this worth? How many bucks should I pay for it? Wow. You've got your microphone there. You guys can fight and pass away your microphone.
I mean,
does that tell you anything?
Yeah, it tells me that they're not really sure what they're looking at.
What Bethesda number do you give this one?
I would give this Bethesda 2 to 5.
Oh, excellent. Perfect. So here's something I don't understand, Tarek. You have to help me with this, okay? The Bethesda starts with the number 1, and number 1 is what?
Non-diagnostic.
So if I were in charge of the world, I would make 0 non-diagnostic, right? So why did they start with 1?
Well, let me give you a little secret. So
yeah?
I was involved in the Bethesda system.
Oh, so I can be mad at you about this, okay? Because this is one of my pet peeves.
And there was no intention whatsoever to have numbers associated with the Bethesda system.
And the new guidelines say don't use the numbers, right?
But we've accepted the fact that most clinicians are using numbers, and now we just have to live with it. But as cytopathologists and pathologists, we were very much against using numbers. So we just listed them in their order, going from non-diagnostic, benign, and so forth, with no intention whatsoever for the numerical system. And then people just ran away with the numbers, and now we just can't take it back.
So you know what my answer to that question is? It's done in Roman numerals. There are no zeros in Roman numerals. So if you had used Arabic numerals, you would have started with the 0. So that's my beef and my complaint. Okay, let's go on. Let's go look at the first case. Now, typically when you have a bunch of case discussions, the first case is some mamby-pamby little benign nodule, right? Okay? And so poor Dr. Geiger is sitting there twiddling her thumbs, whatever, but you have to pay attention to this first case, okay? And so this is a 76-year-old woman. All these are real cases, and I've morphed a little bit the age a few years. I've anonymized this a little bit. 76-year-old woman, sporadic medullary cancer. In the mid-60s, long ago, she had several neck procedures, total thyroidectomy, nodes taken out, et cetera, et cetera. The only operation I did for her was in 2004, 20 years ago, took out a few little lateral neck nodes that cropped up. Her calcitonin has been about 1,000 for 15 years. She would come in every year, nothing on her neck ultrasound, and nothing happened for 15 years. She had some tiny little pulmonary nodules that were there, and we would get occasional chest x-rays and see nothing would ever happen to them. And then she developed some pain from a right scapular lesion, and she had a focus there seen on her imaging. So how do you want to think about that? How do we want to manage that guy?
Well, like I said before, I mean, all of my patients known have cancer. The calcitonin can be in the thousands for a long time. patients sort of live and die by their tumor markers, and then they meet me, and I say things like, I don't really care what your tumor markers are because we're going to look at scans and see how you're doing, et cetera. But, I mean, coming from an oncologist, any of my patients, as soon as they have any new pain, I tend to image them. So this would be suspicious. I would want to know a little bit more. When did it start? You know, is it waking you up at night? Is it severe? Or
yes.
is it explainable? You know, were you in your garden? Whatever, blah, blah, blah. Most of the time it's not, and so we're getting imaging, if not already scheduled within the next couple of weeks or whatever. We're going to bump it up and get some directed imaging, and then probably just get another set of labs just to see what we have with the imaging at the same time.
So she had a sclerotic image, biopsied, it was medullary tumor.
Yeah.
And so if we had Woody here on the panel, what would we do?
Well, Woody is not on the panel, but he's my phone a friend always.
Oh, always.
Or can you do a little bit of spot welding to put her back together and get her going?
We spot welded this thing, and she was fine for another year or so. No absolute problem at all, okay? Then her calcitonin went from up to 3,000 and then to 22,000 over about a 14-month period of time.
She needs a PET scan of some sort. We typically would do
Of
that.
some sort. What kind of PET scan? So the thing I hate about PET scans, everyone just says PET scan, but now we have different isotopes. We have to use the either adjective or noun in front of it. So this was an FDG PET.
Which is fine. I mean, I still tend to prefer those over the dotatate. I think it, even for medullary, I think it shows up the disease a little bit better. That's just my bias and my practice.
Okay.
So that doesn't look good, but that explains why her calcitonin has continued to
Yeah,
increase.
so she had significant progression of multiple pulmonary and mediastinal lesions. Interestingly, most of these medullary folks have badness in their liver. She never had evidence of anything terrible in her liver. I thought that was quite interesting. And then her neck has always been fine. Her neck ultrasounds and the PET of her neck was just fine. So what do you want to do for her at this point? She's an older woman, but she was incredibly active, and she was now totally wiped out. She looked like a wet towel. What do we want to do with her?
So just a couple questions background.
Whoa, the panel starting to ask questions? I mean, what's going? You didn't read the first slide. Go ahead.
Is this her only site of disease, just these two hypermetabolic
No.
areas?
She had half a dozen of these things. I'm just giving you the dramatic ones.
Okay. So, I mean, there's a couple of different things that you could do. I mean, number one, I'm assuming she's had molecular testing done, and we've known this. Has she? You haven't mentioned.
So she was totally managed outside of our fine institution.
Okay.
But what you're getting at is she probably needs...
Yeah, I mean, I would have sent for somatic testing if we had. I mean, the problem is, when you have specimens that are pretty old, you can't do, like, the complete panel testing, although for medullary, you could, I think it's probably okay. 5-10 years old of a specimen in paraffin to be able to send out for somatic testing at least, or we could do liquid biopsy, which is looking at shedded pieces of tumor DNA and being able to test those for any kind of aberrations or mutations.
Okay, so I'll jump ahead and tell you what was done with her. So you've answered this question quite nicely, how to treat her. And this was just her CT scan pre-treatment, and that's just giving you a better view of what you saw on the PET scan there. And she got this drug. Tell me about this drug. You mentioned it in one of your slides.
Pralsetinib. So that is a very highly specific RET inhibitor. Really no off-target side effects. So unlike cabozantinib or vandetanib, which are the multi-kinase RET inhibitors as well, it really just targets RET and only RET, so you have to have a RET molecular mutation or aberration to be able to use.
So she had wacko high blood pressure. Her dose got dumped in half, but she continued on the drug. Yeah. And this is her scan about 6 months later. So she had dramatic resolution of her lesions. Her calcitonin went down from 22,000 to 30, and she's now maintained this for about a year and a half.
Yeah, it's interesting, those really highly specific, so pralsetinib, selpercatinib, the first thing you'll see is a dramatic reduction in calcitonin and CEA levels. It's just the way that the drug works in the peripheral blood with those tumor markers. It really cuts it in half, even before you can see structural changes. So that's really helpful to know. The other question that I was going to ask, this isn't wrong at all, just to be as most comprehensive as I can, even with these really good targeted therapies, I'm still trying to maximize use of locally ablative therapy as much as possible. Because for whatever it's worth, we don't know how, like, the duration of response completely for these newer agents, these more highly selective agents. But patients know that once they start these oral therapies, the clock sort of starts ticking. You know, it's only a matter of time before something happens and they don't start working anymore. So if this were, for example, even if she just had a bunch of lesions in the, periphery of her lung, but the central lymph nodes were causing a problem, or there was just one nodule that was causing a problem, we'll still try to do either external beam or embolization, vascular embolization, any kind of interventional pulmonary ablative therapy if possible too. It sounds like this lady had a lot of
Her
things,
functional status is marked improved. She looked like a different person when she came back
Great.
in. So let's jump to the next case here. So 54-year-old woman had a left thyroid nodule on exam, euthyroid, and the ultrasound showed this thing. It basically took up the whole field of the ultrasound there. Relatively soft on exam, felt mobile. And FNA was benign, so this is on the left side here. And then we look on the right side, and we see this thing kind of vague in there, right? Not the world's most obvious thing. You guys can see that there. And this then was suspicious for a follicular neoplasm. Now, this big, huge thing there on the left was symptomatic, and she had some tracheal deviation. And so the question then is, Leah, let me ask you, what are you going to recommend to her in terms of kind of what procedure she should have?
So this is interesting because we actually deal with this more often than you think. First of all, was Afirma sent off on this lesion?
No, it wasn't. This was done prior to referral.
So I would talk to her about the pros and cons. I would tell her about the risk of cancer in that nodule. And honestly, it's like a discussion with the patient. I mean, if the left side is symptomatic and she wants it out, it's going to come out. But then to remove the right side, it would be just a discussion with the patient. But I wouldn't recommend like a total until like we evaluate that one further.
But even if this were benign, she's got a nodule in there. There may be a second one hiding behind it.
Yeah, that's true. It could be there. I mean, yeah, but it could be benign. And then we took out the whole thyroid, and now we put her on thyroid medication.
So it's one of the questions that always, comes up, and that you have someone come in with a big symptomatic nodule. You know they're going to need surgery, but the real question then is, what is the extent of surgery? You know, if that other lobe is perfect, then,
Definitely not.
Then if you got a benign FNA on the big side, then you can just take out the lobe. So this was, discussed as,
No, nothing. How old was she? I missed it.
What?
How old was she?
What did I say, 50-something?
50-something, okay.
Yeah. Yep. So patient then underwent a total thyroid. I had discussions about rebiopsy. What do you want? She said, listen, if I got a nodule, if there's any question, I go into surgery, probably going to be on thyroid hormone. Another long discussion we're probably not going to have today. Just take the whole thing out, which is a fine value choice, okay? So the initial call from the pathologist said that this was one of these non-invasive follicular thyroid neoplasms with papillary-like nuclear features, okay? The left side was totally benign. This is the little thing on the right, okay? But then, of course, they recut one block due to poor section quality, okay? This is a real case. This came from your department, Tarek, okay? Single vessel shows tumor invasion, okay? Now I got to call the patient up and tell her that she has cancer. So how do you deal with this? How do you think about this lesion, Tarek? What should we tell her? Is she going to die of cancer? How do we have to treat her?
So this is angioinvasive. There's a vessel that's showing that. So this falls into the category of, so when we talk about follicular carcinomas, there's those that are minimally invasive, and these just only have capsular invasion, and they behave really more like benign follicular adenomas than anything else. And then you have those tumors that have a single vessel, which is the cutoff is 4 vessels. If you have less than 4, they're still kind of more in the intermediate risk category. So for the majority of the time, the patients will do well, and they're not going to die from the cancer, but there's always a chance that this will progress. So this definitely, you could opt for either, I would think, lobectomy or total thyroidectomy, depends on your clinical other risk factors that would contribute to that.
Interesting. So when you figure out all these NIFP rules, you can give me a call, okay? Because apparently if I go in and I sample a lymph node and it's positive, but the lesion itself is an NIFP, you still get to call that cancer, right?
But this is not NEFT-P.
I know, but if it were.
If it was NEFT-P, you'll leave it alone. I mean, NEFT-P is basically, it almost behaves like a follicular adenoma. Mm-hmm. So the chances of lymph node mets is close to 0%.
Got it. But I know there have been cases reported where they've identified mets.
But the fact that there is vascular space invasion, that's what puts it in another, it's still a well-differentiated cancer, but it's still a slightly higher risk.
So these are all interesting conversations we need to learn to have. So we'll jump ahead. Ooh, this is going to be a puzzling case.
So what happened in this case?
Huh?
What was?
No iodine. She did fine.
Okay.
I think this case is now like 6-7 years old.
And she had a lobectomy or a total?
No, she had a total because her other side had that huge goiter in it.
Okay.
So that was done for huge structural disease. Okay. So 32-year-old woman. This is not going to be a hard case. Okay. 2-month history of heat intolerance, 20-pound weight loss, and she had a SAW 50-gram thyroid, possible little touch of exophthalmos there. And her TSH was totally suppressed, and her T4 was essentially right at the upper limit of normal, but her T3 was threefold elevated. So, Leah, you want to comment on that kind of T3, T4 pattern? What's going on here?
Yeah, so, well, first I'm going to go back into the symptoms and, the physical exam, because, like we said, physical exam is very important. So with the positive or possible exophthalmos, this makes me think of Graves'. Mm-hmm. Now, in regards to the T3, T4 ratio, there's a lot of data or some data showing that maybe the ratio of T3 to T4 can help guide you whether this is a toxic nodule versus the thyroid gland itself overproducing thyroid hormone. I can't remember what the exact cutoff are, but typically if it's the own thyroid gland overproducing thyroid hormone, you would expect the T4 to be more than T3, but in a nodule, you expect the T3 to be more. There's cutoffs. I don't remember what the ratios are.
So this is the thing they call what, T3 thyrotoxicosis? You guys make up words for things?
Yes.
Okay.
Yes, that's T3 thyrotoxicosis.
Okay. So so what other labs do we want to get now?
I would order an antibody for Graves', the TSI.
Okay. So help me out on this. And I was hoping to have one of our lab medicine people to torture on this question, but they recently changed our, oh, good, come on now, you're supposed to be here. You're getting this question. You come down and grab the microphone here. So back in the olden days, I was really happy with the old cyclic AMP assay, and then you guys switched to this antibody assay. So you got to explain how that is and how it works. I really like the old assay. I'm old-fashioned.
I'm too young, I think.
Huh? So the thyroid-stimulating immunoglobulin assay, right? So what assay do you use now, and tell me about the cyclase assay.
So you're not talking about T3, T4. Now you're talking about the TSI, the Siemens assay.
Uh-huh.
That I think the main reason for that change, Dr. Kakoda oversees that test, was that it's an automated test platform as opposed to the previous test was more manual and more labor intensive.
So how does the old, so you just like putting a drop of fluid in your expensive machine and then having a number come out, right? So how does the old test work?
I don't oversee that test, but Dr. Gupta.
I actually know how it works, but anyway.
Yeah.
Siemens assays actually also detects blocking antibody.
Both.
Which is N-terminal, not really detect.
So I guess just to
blocking antibodies, it blocks the CSS receptor and can cause hypothyroidism, but that will not be detected in them.
So I guess the question is, does your new assay detect blocking antibodies?
I think in the text, you don't think so? You've been in touch with Dr. Kakoda about this assay.
Oh, we're having a fight with the audience now. This is good. Yeah.
I can just say a quick comment. So I had
Okay.
Actually, there are two different blocking epitopes. The C-terminal is not detected, and that's the basis of that assay, that because you're not detecting, it only detects stimulating antibody. But they do not know that there is N-terminal blocking antibody, which are detected. Okay? And I think they know, Siemens know that, because I remember that when they were developing and doing the assay initially, I told them, but they don't. Now with the structurally also we know where the N-terminal blocking antibody binds. It's pretty much same place, same areas, common or stimulating antibody.
So Dr. Gupta, for the people online, Dr. Gupta's comment simply has to do with, and I'll editorialize, kind of being able to distinguish stimulating versus blocking potential antibodies. But the old test I really liked. It was they took these Chinese hamster ovary cells and they transfected them with TSH receptors, and you put the serum in there and you measured cyclic AMP coming out. And I thought that was really cool because it gave you the level of stimulation, but these people had blocking antibodies, you would see a decreased level. I thought that was a cool test. You guys hate running it because it requires work, right? Okay, good. Okay. So any imaging needed in this patient? So thyroid stimulating immunoglobulin levels are high. Okay. Do we need to get any imaging on this patient?
so
We'll get an ultrasound, of course.
yeah. I mean, and I know like the new guidelines that are coming out are probably going to talk about the Graves, when to order an ultrasound, when
Yeah.
not, and it's patient preference. But I would, because it helps you. Another thing you can do is you can see the flow, and it kind of helps like guide you. So I like getting the ultrasound. It's easy, no radiation. You can do it in the office. You get your results right there and then. So I do.
Okay.
Maybe I'm over.
So, okay. Radioiodine scan, would you get that in this case?
Let's start with the ultrasound first. What did it show?
So ultrasound just shows a big diffuse gland, hypervascular.
No nodules. Seen.
No nodules.
Yeah, I probably would get an uptake scan. That's technically what the next step should be.
Okay.
What about the flow? Was there a lot of flow?
Increased flow, hypoechoic on ultrasound, increased flow.
That's
So do you want to talk a
bizarre.
little bit about how you initially managed the hyperthyroidism?
So in that case, I don't know. I wouldn't get an. Well, let me circle back. I wouldn't get an uptake scan because if there was like decreased flow, then I worry about thyroiditis. But,
Okay.
But if there's increased flow,
Even if the TSI is high.
yeah, I mean, well, you could have Graves' disease, but it's not the Graves that's active. It could be thyroiditis. And
Oh,
you
so
could
you
have
could have
both.
fleas and lice, as we used to say in Texas.
What's that?
You could have fleas and lice.
Exactly.
Two separate diagnoses.
I don't know
Okay.
which one's better, but
Okay. So how are you going to initially manage this patient?
for her, I mean, at this point, it's medical treatment.
Yeah.
I mean, we've diagnosed Graves. We start her. I mean, I talked to her and we start her on methimazole.
Okay. So that's your drug of choice. Okay.
Yeah.
And then once you got the patient controlled, still on 30 a day of methimazole 6 months later, what are you going to recommend for treatment?
So usually, I mean, it's very rare to see someone really not responsive to methimazole. Most of them actually do really well, and then eventually we keep them on it. After a year and a half, we stop it, and most of them actually stay in remission. So I always go medical therapy first. Now, if there's a reason why I'm really not able to, and most of the time they end up going to definitive treatment is because of side effects. Like either they got a rash or they couldn't tolerate the methimazole, or something happened or they want to get pregnant. I personally don't, I mean, everyone's different. I typically don't do radioactive iodine. I typically talk to them about surgery unless iodine is what they wanted. Now, with a very large goiter, I mean, the chance of getting it the
It's like
first
50
time.
grams.
I mean, yeah.
Okay.
I mean, you could do, if they really wanted the iodine ablation, their eye disease apparently isn't that bad, you could go ahead and proceed. I mean, it depends on also if they want to get pregnant or not in the next 6 months. I can't remember how old she was. Or surgery, you just take it out and we're done. And then
Got
you
it.
do levothyroxine after.
Okay. So we got
So
some
it's
options.
patient preference.
Got it. Okay, let's jump on to something else. We're going to hit a bunch of topics. Ooh, this is going to be a nice one here. So this is a patient with a left thyroid nodule, and this is before the patient was referred. So a lot of this stuff happened before I got a hold of the patient. College student noticed the left thyroid mass, And an ultrasound showed a 4-centimeter solitary hypoechoic solid nodule that was there, and had an FNA that was suspicious for a papillary cancer, and in another city and state underwent an uncomplicated left thyroid lobectomy, okay? And how old is this slide, Tarek? How old is this slide? Given the title on there, have I dated myself?
Oh my God.
Huh?
Well, I mean, the terminology just changed.
Yeah, so okay. So this came back a cribriform molar variant of papillary cancer, okay? And you very nicely mentioned in your talk that they're thinking that this may not be a papillary cancer. Why is that?
Well,
I know it looks different, okay? That doesn't count. But in terms of its molecular characteristics, et cetera.
So it's not really showing any of the molecular or immunohistochemical characteristics of papillary thyroid carcinoma. These tumors don't stain with thyroglobulin or PAX8 or TTF1. Occasionally, it just so they're not sure what the cell of origin is, and they're not sure what kind of So that's why they put it in this new category of tumors of uncertain histogenesis.
So here's the other weird question: do they secrete any thyroglobulin at all?
I don't know the answer to that.
So I couldn't find a good answer to that.
Yeah.
Do they take up radioactive iodine at all? I couldn't find a good answer to that either. Do you guys know? Anybody know? This was a real head scratcher, so we got some work to do. We can publish another paper, We may even get tenure, by doing that. Okay? So this is what happened. And it was 3.9 centimeters, and there was extrathyroidal extension into the surrounding strap muscles. It was kind of a really weird case. This was one like the 2 microscopic cells. This was weird. And so the patient was sent in for evaluation. One attached lymph node was negative, and we re-looked at the pathology and agreed with all of this. So what are we going to do now? What are we going to do now? And this is before we really understood what this tumor was. We just thought this was a variant of papillary cancer. What are we going to do, Leah? Just a lobe was taken out.
So you said there was one lymph node involved?
Was negative.
Oh, one lymph node was negative.
Yeah, 3.9 centimeters, but gross extrathyroidal extension, even by today's definition of that.
Oh, gross extrathyroid.
Yeah, growing into the strap muscles,
iodine. Radioactive iodine, I would send her to genetics.
Huh?
I would also screen her for genetic diseases.
Oh, interesting. Okay. So she had all this stuff done that was all negative because the thing you're most concerned with is what?
The familiar edematosis.
Yeah, so APC gene was negative.
FAP.
And she had no symptoms or anything.
I have a question. Hold on. Can I ask a? Sorry, am I?
Okay,
allowed
you
to
only
ask
get
a
3
question?
questions, and you've used
two.
2 of them up already, Jessica.
Just because this is, I'm way on the other end of all of this. If
Yeah.
you had a patient who presented to you with a 4-centimeter nodule that you were suspicious for cancer, would you just do a lobectomy, or would you plan? Is it age driven?
Well, it's Thursday, but being the Monday morning quarterback, I probably would have argued for a total initially after discussion with the patient. That would have been my default recommendation if this were as Mike said, my mother-in-law. Okay.
I was just wondering from just a general standpoint.
Very good
because
question.
I thought, I mean, again, just an oncologist, but 4 centimeters seems kind of big just to.
Right. But sometimes
take
in
part
surgery, it's like playing cards. We have to play the hand that's dealt us, that kind of thing, okay? So the other thing, too, is she just had a lobe taken out, was not on thyroid hormone, and her TSH was 3.4. So Leah's going to write a script, right?
So she was just a lobectomy? I would recommend completion in radioactive iodine.
Okay. So this is what her ultrasound looked like. So she had the left lobe was surgically absent on here. This is her esophagus. This isn't anything horrible. And then the other side looked pretty good. On that left side, we really want to scrutinize for the presence of any nodal disease. And there was nothing. And when you do an ultrasound, you see these nice white funny things. Those are metal clips that were left behind from her first surgery. Other side looked pretty pristine. And just pay attention, there was one tiny little cyst in the thyroid right there, but there were no solid nodules at all. So yes, after a lot of discussion and screening and weeping and gnashing of teeth and everything, went ahead and did a completion total to allow her to receive radioactive iodine, although these days we don't know whether that may have been the right thing to do. And so the real question then is, how do we manage this patient's identical twin sister that was adopted into the same family, okay? I can't make this stuff up. Here's her ultrasound. Her ultrasound was totally pristine. The only thing that was the same is they had a cyst in the exact same location.
I mean, honestly, her genetic testing
I have
was
no
negative.
idea, huh?
Her genetic testing was negative. So,
What?
I mean, the genetic testing was negative. If it was positive, that's a different story.
Right. So, again, basically, for psychotherapy, we did a baseline screening ultrasound. Everything's fine, so forget about the sister. Okay, so probably sporadic disease on this stuff. So this is a 76-year-old woman, huge left goiter. I'll shoot through this one pretty quick. And the ultrasound showed that it was all in the neck. The goiter was huge on the left side, so I always ultrasound the contralateral side first, okay, so I don't get distracted by the enormity of it. And there was some tiny little, probably spongiform nodule hiding in there, but nothing else. And then the goiter, this is starting at the cephalad part, goes all the way down. I thought the cystic area kind of looked like a rabbit. What do you guys see in there? And goes all the way down, and I can't get to the bottom of this thing with the ultrasound. I'm angling down in the anterior mediastinum. I can't see the bottom of this goiter, so what should I do?
Get a CT scan.
So here's a CT scan, okay? So the trachea comes like this and goes over and branches here. So most of this goiter here is down in the chest, this big thing. So this is one of these tip of the iceberg syndrome. But the point I wanted to make here is that if you can't see it on the ultrasound, get a CT scan. And of course, on cross-sectional imaging, she's got the typical tracheal compression, big, huge goiter there, going all the way down into the chest. So we went ahead and took out her left lobe. Most of these, jump ahead, this is not a surgical talk, but most of these, even though these things look huge and ugly, these days we can get them all out pretty much through the neck, because all the vasculature comes from above. Now, we're going to change gears a little bit, okay? What is the title of this slide? Another great thyroid case, okay? Now, why would I title the next case this as opposed to next case? Help me, Tarek. What? No. Those are the 4 base pairs, okay? So this is another great thyroid case. We're going to all have molecular answers to the next puzzle, okay? I've given you guys a great hint. You didn't even want to bite on this, okay? You guys ready? These are all be kind of quick shot cases, okay? Huh? You guys are trying. Oh, I actually have 2 hours to do this now, Joyce? Oh, these guys can't wait to get out of here, okay? 68-year-old man, bilateral thyroid nodules, each measured about 1.7 centimeters, okay? So here, help me read this one on the right side. Yeah.
So from where I'm looking, this is a spongiform nodule. It has regular borders. I mean, you see areas of increased, like, hyzoicoid.
Yeah, I love it, what you said. You said spongiform, right?
Yeah.
Well, the pathologist said that this was a TIRADS 4 lesion with hyperechoic foci or microcalcifications in it. Why did you respectfully disagree with a radiologist who's board certified and all that stuff?
Because the thyroid nodule looks
What?
like a spongiform nodule.
Why do you call a spongiform nodule?
Because it has, so spongiform, most of the time it's like 50% solid, 50% cystic, and then it has septations in it.
Uh-huh.
I don't see areas of calcification. This is just normal.
What are these things?
That's just from the thyroid tissue. Colloid.
Yeah, okay. Now, why can you read these better than the radiologist? That's what I want to know. So one of the teaching points I wanted to make is we often get these nodules sent in with very high TIRADS readings. Okay, and the patient, is told, you're going to die, you got to go see the surgeon, they're going to biopsy you, then they're going to cut you open and take your thyroid out, okay? And so I do the ultrasound, and I see exactly what you described. You see this microcystic pattern, and the hyperechoic foci, and now it's hard to tell on a static image. You do much better fanning through the ultrasound in real time, but you see that these little hyperechoic foci are always associated with the fluid component. So basically, it's inspissated or precipitated colloid in there. And when you cut these things open, you see this goop. See, surgeons are great. We get to take this out and cut them open all the time. It's great fun. And you see this little goopy colloid, and there's this little, looks like a little crystal of amber sitting in there. And that's exactly what these hyperechoic foci are. And so I would agree. I would interpret this as a typical benign spongiform nodule. So I think that's kind of the most common overreading I get sent into the office. I didn't show you these slides ahead of time, right? I didn't give you any hint. You didn't see the list of answers in my pocket or anything. You got that one, okay? What about this one on the left side?
Now, I don't know if there's a little bit of solid component on the side, but this is predominantly cystic nodule. With just
actually, it was more, so the exposure is always difficult on this, but this was solid and hypoechoic.
It was, sorry, a solid?
Yeah, this thing was solid. I mean, it's quite hypoechoic, and I know it doesn't project well.
Oh, okay. I'm sorry. I saw it cystic from here. I mean, this is if this is a solid nodule, this is a markedly hypoechoic nodule, and that raises this risk of malignancy and should be biopsied. How big was it?
Okay. Now look at this little guy here. Look at this little funny thing next to it.
Yeah, it has irregular borders.
What do you think about those margins on there?
It's lobulated irregular margin.
Yeah, it looks like kind of a Canadian maple leaf. That's why I tell the fellows what irregular margins look like. What do you want to do?
I mean, the one on the left needs to be biopsied.
Okay. Well, they actually both got biopsied. So that side was benign, as you expect, so you called that one correctly. And this one came back, atypical cells, question medullary cancer. Question, unsure. They were head scratching on this one. What do you want to do?
Call pathology? No, I'm joking.
No, what Tarek will
Check
say,
calcitonin.
didn't you read my report? Can't you read?
I check a calcitonin level.
Huh?
Check calcitonin level. And then, I would repeat the FNA and try and get a better sample. And then I would also check calcitonin and call cytology.
Well, we cheated. We sent it off for the gene expression classifier,
yeah,
okay?
you could do that too.
And it came back medullary cancer, 100%. So that was very, very nice. And then they sent it off for mutational analysis, okay? And this turned out to have a 918 mutation. So my question for the panel is, in this, 50-year-old patient, is this sporadic or familial disease? And can we tell from what we see up there on the slide?
So this was testing on the tumor itself. So we know this was testing on the
tumor itself, yeah.
Yeah. So given her age, and I don't, without knowing all the family history and things like that.
No family history.
If I were a betting person, it's probably sporadic, but that doesn't get you out of sending her to genetics for germline testing, because there can be some de novo cases too that we've seen.
Okay.
But this information only tells you it's at least a somatic mutation. Doesn't give any information about germline.
Okay. So let me ask a weird question another way. So in MEN2A, what are the most common mutations that are seen? Or are they?
This one is one of them. I don't know off the top of my hand.
Well, most of these are like 634. They're the low number ones, up in the 600 range. They're on the extracellular domain. This is the RET918 is the intracellular one, and it's the mutations that's associated with MEN2B. So do we think this patient has MEN2B?
You have to. You're going to check germline anyways.
But it's more common sporadic.
Right.
Yeah, but I guess the weird question I'm trying to ask backwards is, if you have a 918 mutation off of an FNA in an adult, is this more likely going to be sporadic, or is it going to be MEN2B?
Sporadic.
Yeah, because MEN2B, you know that when they're infants, okay? They have marfanoid habitus. They don't make tears. They get medullary cancer, when they're 1 year old. They get very, very aggressive medullary tumors.
I will say I've had 2 patients in my career who've been de novo MEN2A, not 2B. But I've had patients with absolutely no family history whatsoever, and then germline testing shockingly comes back positive.
Oh, we see that all the
but not
time.
2B, yeah.
Yeah, but it's just interesting. About half of the medullaries have sporadic 918 mutations, which is the same site. But everybody was careful, and the patient got genetic screening, was negative anyway. Okay.
Well, this is a bad marker, though. I mean, how did the patient do? I mean, that's usually
Recently operated on. 33-year-old man.
Can I ask another question?
Oh, you want her? You want her third question? Yeah.
So, so what happens then when you disagree with the radiology report? So when they give it a high, TRADS, 5 or 6, and you think it's benign. So the discrepancy is so huge.
Right.
How do you address that in EPIC or whatever?
So when I'm doing the ultrasound in the office, I show the patients the images, and I show them why on the screen I respectfully have a different interpretation of the images. And I will document all of that in the note. But the other thing that I will do is I'll say, listen, you're going to see two different things in the record. I'm interpreting this different. I will always see the patients back in about 6 months and re-ultrasound them, kind of just to make sure, just to reassure them that everything is okay. I'll have a discussion. Some of them may elect to have a needle biopsy that I, in vacuo, would not have done or recommended. So again, you have to individualize that.
So there's no mechanism for communication with the radiologist. So because you're saying this happens all the time.
Yes.
And so there's no mechanism for feedback to the radiologist. So maybe these things.
Mm-hmm.
We've asked for a repeat. I mean, Neil can attest to this too. I mean, we've sometimes asked for addendums or the record to be corrected to reflect what you see or what you've reviewed, especially in a tumor board setting when there's consensus.
Mm-hmm. But again, the subtlety is they often may be reading the images off of static images, and I'm cheating, and I'm both the technician and the interpreter, and I'm fanning through this in real time in the office, so I may have some subtle hints that they don't have. Because if I cut in one plane of view, that hyperechoic foci may look like it's in the solid tissue. And if I move a tiny bit, I say, oh no, it's really floating in the solid stuff. So again, I may have some top secret information they don't have. Okay, we're going to be on time. 33-year-old man, right neck mass on exam. Give me an ATA or TIRAD score. Well demarcated, ISO to slightly hyperechoic. Make sense?
It has kind of like an irregular halo, so it's thick on one side and gone on the others.
Okay.
And the margin, it's not really that regular. So it's
no calcifications.
No calcifications. I don't know about the flow.
Okay. Transverse looks the same.
Yeah.
Okay. What do you want to do?
Biopsy it.
Atypia of undetermined significance, okay? Now, you said that only a certain percent should be AUS, okay? I think you guys have a rubber stamp in pathology, and you just stamp AUS on most of the specimens, okay? For you young people in the audience, you don't know what a rubber stamp is, just think dot phrase, okay? You guys will be okay.
So I have to defend pathology.
Are you going to defend yourself? Huh?
So the Bethesda system recommends that the AUS rate be less than 10%. Mm-hmm. As of the last calculations we made, we are at 7%. So we're well below the national average.
Unless you see my name on the top of the report.
So you're welcome. You're welcome for us providing you such an amazing service.
Excellent. So I have all my nurses are lined up there, okay? What's the percent rate that we see for AUS? They're going to take the fifth on this. Okay, good. So gene expression classifier was suspicious, okay? So what do we want to do now? Look.
I recommend taking it out. So it's 50%.
Oh, but we'll look at the mutations, right? Oh my God, look at this. 33-year-old person has a Dicer 1 mutation. What do we do with this?
I mean, I would still recommend.
Huh?
I would still recommend surgical resection.
Oh, yeah, we're going to take surgical cases. Of course, I'm going to take this out, okay? Any different thoughts, workup, evaluation if you've got a Dicer 1 mutation?
Looking epic on Slicer Dicer.
What?
I think it was a joke. Looking epic on Slicer Dicer.
Huh?
Silly joke. Look at Slicer Dicer and epic.
So, with just like the FAP case, the question is, could this be a familial syndrome that we're dealing with? So, could this person have a Dicer 1 syndrome, or is this most likely sporadic disease?
I don't. I can never make a judgment. It's always better just to send them to genetic. You don't want to miss anything.
Okay. Had no other sequelae, didn't have any of these, pulmonary bullae and all these other weird things that they get often when they're young. The thyroid presentations can be variable in these folks, so that didn't help me that much. But what if I told you the mother had papillary cancer and the brother had a follicular adenoma? Okay? I know surgeons don't get family histories, but I made an exception in this case.
Yeah, so typically the risk of thyroid cancer increases if one family member can put you at a slightly higher risk, but to actually say there is an increased risk, it has to be 2 immediate family members. So if the brother just had a follicular adenoma, that's a benign, so that doesn't really count. So it's really just the mother with thyroid cancer.
Yeah.
No, I would just add to that. I mean, these patients are also at higher risk of having poorly differentiated thyroid carcinoma and follicular carcinoma. So that would further emphasize the fact that needs to come out, because that would only show a suspicious on molecular testing, because these are going to be RAS kind of related tumors. So you want to make sure that these patients don't have the carcinoma.
So the thing I find interesting is that like a decade ago, we were scratching our heads on this like familial papillary thyroid cancer. We didn't know anything about it. And we keep getting smarter and smarter. We're understanding the FAP patients. We're starting to understand these Dicer 1 patients as well. So had a total thyroidectomy, given this thing was almost 4 centimeters, and we were suspecting a cancer with maybe a higher chance of something nasty in there. Now you're going to get it again, Tarek, okay? Pathology, okay? High-grade, minimally invasive follicular variant of papillary cancer. There were 8 mitoses, okay? Why do you guys say per 2 millimeters? Is that just how big your microscope is? You got to explain the 2 millimeters to me. I don't understand that.
So, since ever I can remember, we reported mitoses per 10 high-power fields.
Right, that's what I remember.
But now, back then, scopes were all the same size, and the optical field was the same, but now we have many different brands, and the microscopic field could vary from one scope to the other. So for consistency now, we do it by 2 millimeter scope. So depending on the size of your microscopic field, that's how you're supposed to assess the number of mitoses. So now, with the new WHO classification, we're using 2 millimeter square rather than 10 high-power fields.
So how do I deal? I mean, normally when I think mitoses, I think something like really, really bad. But there were mitoses, but the rest of it looked shockingly bland or routine. So help me understand this disease.
This is a new entity. I mean, if it's over 5 mitoses, 5 or more mitoses per 2 millimeters squared, that qualifies as a high-grade carcinoma. And the fact that it's invasive, again, so that puts it in the high grade. So this potentially could behave as bad as a poorly differentiated thyroid carcinoma.
Okay, even though we're not seeing any insular components or necrosis or anything like that.
Yes, this is again would be this is the new entity that I talked about earlier today, because we're recognizing that these tumors did behave more aggressively, and for the longest time we did not account for that because they were being diagnosed alongside the well-differentiated thyroid carcinomas. Now, I can tell you from my experience, usually you don't see increased mitosis alone. Usually you see evidence of angioinvasion, you also see evidence of necrosis. So when there's only mitoses that are increased and everything else looks bland, it's still too early in the game to know how this particular patient will behave. So that may be one of those patients that may not behave as bad as the other well-documented differentiated high-grade carcinomas.
Okay. So that's one of the reasons I showed this case, not only the molecular stuff, but also we just move ourselves out of our comfort zone as soon as we start thinking we understand what's going on. So the thyroid globulin was undetectable with a TSH of 0.4. Patient ended up getting radioactive iodine with a basically almost undetectable TSH with stimulation. Actually went to genetic screening that was fortunately negative. So interesting sporadic case. Let's do another great thyroid case. This will be the last great thyroid case. 52-year-old woman had an executive health CT scan, okay, and had a small right thyroid nodule. 1.6 centimeters, a little bit splotchy, heterogeneous, looked well demarcated, hypoechoic, no calcifications.
This is actually a little bit of a concerning nodule, because if you look at the solid component in the center, it's not very regular. It's kind of like extruding into the tissue surrounding it. I don't even know if that's fluid, a little bit around it. If you look at the angle between the wall, it's actually like an acute angle. So this is actually a suspicious nodule to me, and I would biopsy it.
Got it. So gonna get a there's a transverse view, so it's not a taller than wide or anything like that, okay? So I got a biopsy, okay? Of course, it had to say AUS, okay? So my talk was easy. I just had to copy and paste. I didn't even have to type it in each time, Tarek, okay? Oh, I'm not going to be on your Christmas list this year, am I?
Sometimes it's operator dependent.
Okay, good, okay. So the gene expression was suspicious, okay? So now we have to send it off for molecular profiling, because this is another great thyroid case, right? And it had this bizarre mutation. Anybody want to tell me what the pathology is going to be on this lesion, given this GLIS3 Pax8 rearrangement? Have we stumped the audience? This is like a zebra one. I had to throw in one totally weird one.
Is this
You win a wash,
hyalinizing trabecular
Oh my
tumor?
God, you win a washer and dryer, okay? Hyalinizing trabecular tumor, okay? So this mutation is pathognomonic for this very rare lesion, okay? What is this? Is this a papillary cancer?
It's now placed, for the longest time we considered this a benign tumor, but now in the recent WHO, now they put it in the low risk neoplasms. Just about almost all the cases behave in a benign fashion, but there are rare reports of metastases. And these are like
and that's exactly what this patient knew
case reports
afterwards, because she looked it up on the internet, okay? So if there are rare cases of metastatic disease, and this patient had an executive health screening CT, is she going to want maximum therapy or minimum therapy?
What she wants or what she should get?
Well, tell me what she wants.
Yeah, what she wants. It depends on her level of anxiousness.
Oh, through the roof. 11.
Then she would want,
Okay.
total.
So took out the right lobe. The other side was pristine. Showed exactly this. Incidentally, she had a little 9-millimeter papillary sitting in there, so she was very happy with all of that. Okay. We're at our time. I had another bizarre, weird case, but we'll skip it in the interest of time. And I just want to thank the panel for their engagement and surviving another case session.